Hi, you guys. Welcome back for our daily practice questions. It is day 198 and our Pharm series continues. But as always, I like to first start with my introduction and disclaimer before getting started with our questions for today. So, for those of you who are familiar with me, hey y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner, and I am the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, review books, digital flashcards, Q banks, one on one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. But y'all know my disclaimer and reminder is that we know there's no absolutes in medicine. We treat on a patient by patient basis, and any of the questions that you see here, I have designed and created based on the current guidelines that are being tested on the ANCC as well as AANP exam. Now, any of my videos where I'm teaching on things that we currently do in practice, I will always say that so there's no confusion. So, with that being said, let's get into question number one for today. But before we get started, don't forget to hit the subscribe button so you're not missing any of my videos. And if you're looking to gain access to my MP Test Success Toolkit, it is free and linked in the description. The link to my website is also in the description of this video, and it houses all the resources that I offer. Now, for those of you who are looking to enroll in the upcoming 5-week review, I have 3 spaces remaining, and class runs from August the 11th through September the 12th. If you're looking to join, click the link in the description and grab your space while it's available. All right, question number one. A 7-year-old presents with a low-grade fever, runny nose, and a fine pink rash spreading from the face to the trunk. What is the most appropriate outpatient NP management? Is it A, to prescribe amoxicillin, B, report to public health and advise isolation from pregnant contacts, C, begin IVIG therapy, or D, order a throat culture and start steroids? Take a moment and tell me what you got, you guys. All right, so I always recommend reading the stem of the question first, as it allows you to slow down to ensure you're answering what is even being asked of you. So here, the stem of the question states, what is the most appropriate outpatient NP management? All right, so it's a treatment question, and I always tell y'all, look to see if they provided you with a diagnosis, if they're asking for a treatment option. And if the diagnosis has not been provided, you got to run it back and look at those assessment findings because we got to know what it is to be able to treat it. So since a diagnosis is not provided, let's look at these assessment findings. So we have a 7-year-old who presents with a low-grade fever, has a runny nose, and a fine pink rash that spreads from the face to the trunk. This is classic presentation for rubella, which is also known as German measles, and that's the key. So let's do 2 things. Y'all know I always tell you with Brittany's Brilliance for rubella, think of a bell, like old classic bell shape that you hold at the top and shake side to side to ring, to remember how the rash spreads from face to trunk. So it's going to navigate from the smaller portion of the bell, being the face, down to the trunk. Also, typically with a fever, runny nose, associated with it, remembering that this is something that resolves on its own. So the main things that we typically do for these patients is supportive therapy. So that's the way to quickly identify it. But also remembering that it is German measles. Sidebar, I want to say that before I go down the German measles route. With that for rubella, I had a question on yesterday's question asking about rubeola because it's also a descending macular papular rash. Now, I will say for classic presentation, rubella is classically known from its pattern to travel from face down to the trunk, whereas rubeola's classic identifier is that blotchy rash and Koplik spots, but it also descends downward. Now, if they're getting so in detail, which they don't do on boards because they want you to look at what is commonly notified. So if you see this, because majority of these presenting rashes are maculopapular rashes that do descend downward, you pay attention to the key identifier, right? So rubeola, again, the Koplik spots, blotchy rash. Rubella, specifically, it's face to shrunk. It's like that classic presentation with it. And I don't want to say all the other ones because we're about to cover some of those today, but making sure you pay attention to that. But what I was trying to explain on yesterday too with that question, because it's a great question, but remember that rubella, because it goes face down to the trunk, rubeola, it does, if it starts on the face, then it will go like to the ears and then down to the trunk, etc. But majority of these descend in nature. The rash is a descending rash, okay? But pay attention to the key identifiers if in doubt. Remember, I always tell you, know the things that present similarly, know how to differentiate them, right? So if you get there and you get stuck, say, did they mention Koplik spots? Have they only mentioned that it went from the face to trunk? Because specifically, they don't usually say that it's just descending downward. Descending downwards meaning like even if it was noted on the trunk, it's starting to descend downward on the lower extremities, etc., stuff like that, you know. But if they're specifically saying face to trunk, they're emphasizing this classic presentation for rubella. Now, down the German measles route. Remember, rubella is German measles. Rubeola is measles. Rubella is the German measles. So this is also a reportable condition. And the reason why B is your best answer to report them to public health and advise isolation from pregnant contacts is because it is teratogenic. So you want to stay away from pregnant women, okay? So report to public health, advise isolation from pregnant women, okay? And then supportive symptomatic management for the child. But the main thing to pay attention to with that is it is reportable and you want to isolate from pregnant women. And I typically get the question for how long. Think 7 days or a week from once the rash has the onset of the rash. That's the best way to say it. Okay. So from onset of rash, give 7 days to be isolated from pregnant women. All right, question number 2. A 2-year-old presents with fever, refusal to eat, and vesicular lesions on the hands, feet, and inside the mouth. What is the first line outpatient NP treatment? Is it A, to prescribe oral acyclovir? Is it B, to start topical mupirocin and oral antibiotics? Is it C, to recommend supportive care with fluids and pain relief? Or is it D, to refer to dermatology for biopsy? Take a moment to tell me what you got, you guys. All right. So, stem of the question here states, what is the first line outpatient NP treatment? And so, remember, when they're asking for a treatment, so when they're asking for treatment, remember to look to see if they have provided you with a diagnosis. There's no diagnosis provided here, so we have to run it back and look at those assessment findings, right? So we have a 2-year-old who comes in with fever, refusal to eat, and vesicular lesions on the hands, feet, and inside the mouth. All right, y'all. If you didn't know anything else, this is classic for hand, foot, mouth disease, right? Lesions on the hands, the feet, and the mouth. And this is why the child is refusing to eat. Their mouth is irritated, it's sore, it hurts, right? And then, with hand, foot, mouth disease, they typically have a fever associated as well. But remember, again, think about this. Remember that the hand, foot, mouth disease is secondary to the Coxsackie virus, right? Coxsackie virus. So it's viral. So we're not giving any antibiotics or antiretrovirals or anything like that. We're going to do supportive care. See, it's going to be your best answer. You're going to do supportive care to help with that pain. We're going to do fluids to keep them hydrated because we know that they're going to be irritated and not want to eat. So a lot of times that's where you see like the popsicles and things that are soothing, but allowing for hydration and something that the kiddos enjoy. But supportive care and management, remember, is viral, is secondary to the Coxsackie virus. And so we're not doing any antibiotics. It's self-limiting supportive care all the way. All right, question number 3. A 3-year-old presents with 5 days of fever, strawberry tongue, erythema and swelling of the hands and feet, and a rash to the trunk. What is the most appropriate next step for the NP in the outpatient setting? Is it A, prescribe oral prednisone and follow up in 48 hours? Is it B, reassure parents and monitor symptoms since it's likely viral? Is it C, refer urgently to the hospital for IVIG and echo? Or is it D, order a throat culture and start amoxicillin? Take a moment and tell me what you got, y'all. All right, so stem of the question here states, what is the most appropriate next step for the NP in the outpatient setting? So let's see what we have going on. We don't have a diagnosis on board. So let's check out these assessment findings and see what we're working with. So we have a 3-year-old comes in with 5 days of fever, strawberry tongue, which is the key identifier, right? Alert, alert, alert. Strawberry tongue, erythema swelling of the hands and feet, and a rash to the trunk. Y'all, this is classic for Kawasaki disease, right? That strawberry tongue is your key indicator here. Strawberry tongue, Kawasaki. Rash that follows face to trunk, rubella. Coptic spots, blotchy with that macular papular rash, rubeola, right? Sores on the hands, the feet, and inside the mouth, particular lesions, think hand, foot, mouth disease, right? So pay attention to the key identifiers. So again, strawberry tongue is your key identifier here. So remember, with Kawasaki disease, we're going to do C. We're going to refer them urgently to the hospital so they can get IVIG and an echo. Echo is one of those key things because remember, Kawasaki disease, they are susceptible to vasculitis. And so echo is going to help us to determine if they have this or not, because the vasculitis can cause murmurs. So you want to evaluate and treat accordingly. And remember, with Kawasaki's disease, we do our symptomatic management, we do our IVIG, we do our aspirin. So because we are primary care and providing services outpatient, we're going to refer them urgently to the hospital so that they can get the IVIG and make sure they get their echo. Okay. All right, you guys. I hope you found this helpful. As always, be sure to like, comment, subscribe, and share with whoever you may think may find this beneficial as well. But y'all know what to do. Y'all make sure y'all meet me back here. And if you need any of the resources, excuse me, that I do offer, as always, feel free to reach out to the nursing studio by giving us a call. You can also shoot a text message to that number or shoot us an email that's listed on the screen. As always, everything that I offer is linked in the bio of this channel, including my website. My website is also housed in the description of this video, as I mentioned earlier. And this houses everything that I offer. It's easy to access and see, and it's broken down for first-time test takers and those who are retesting. All right, y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye, y'all.